Hello and welcome back, guys. This is Dr. Ajinkya here. So, I hope all of you guys must have watched the first OPD case discussion, the first video in this series. So, I'm going to do an unlimited, infinite number of cases on this series. So, whatever cases I get in my OPD or whatever cases I have already stored, I'm going to show you all those from the clinical aspect up to the radiological, the endoscopy, the surgical, the medical therapy aspect. So I'm going to basically clear all the points. So today in this video, this is a second case of OPD discussion series, and as you can see on the screen, this is a patient. This is a male patient, a proper middle-aged patient, ranged from age group 40 to 50. So he's a middle-aged patient, and as you can see, the clinical profile of this patient is completely normal. This patient had come to me with complaints of bilateral nasal blockage, bilateral nasal discharge, frontal headache, ethmoidal headache, and in bilateral regions, and mild tenderness over bilateral maxillary region. Now, as you can see, the patient's clinical profile is completely normal. There's no obvious neck swelling. The lips, the philtrum area of the maxillary and the mandibular area of this patient is completely normal over here. As you can see, the nose is also appears to be normal. There's no proper obvious bulge on the dorsum area or the tip area. However, the eye region has been covered for the legal purpose. So the patient had no changes of orbital cellulitis over the orbital region. Neither did the patient have any frontal obvious swelling or frontal protuberance, excessive protuberance, anything like that. So bilateral nasal obstruction. So the first thing, when the patient gives you the clinical history, the patient has bilateral nasal blockage. So it could be because of, now, the duration of this bilateral nasal blockage was around 2 years, minimum of 2 years, between a range of 2 to 3 years. Basically, the patient was not aware exactly, but a range of 2 to 3 years, the chronic. So this becomes a chronic case, and because of bilateral nasal obstruction, the differential diagnosis which should come to your mind at this first step should be anything which is a bilateral nasal blockage, which could be bilateral inferior turbinate hypertrophy. It could be gross DNS to both sides, which could be S-shaped DNS. Also, he's a middle-aged man, maybe around the age of 40 to 50. So you should or may consider malignancy in such patients if at all the history or the complaints goes towards more of a malignancy, such as nasal bleeding or excess protuberance or obvious swelling on the cheek area, or you can say loosening of the teeth in the maxilla, in the maxillary area, or you can say the patient is having foul smelling with blood discharge and loss of sensations over the cheek area. So those points are more towards malignancy, carcinoma, CA maxilla, but this patient had nothing like that, so you can rule out at least the maxillary at the clinical stage. But let's see what the endoscopy and the CT scan reveals for us. Then we also can think of bilateral nasal polyposis, because as we discussed in the last case, it could be, if it was unilateral, so it was infected AC polyp for a long-standing case. This is bilateral, so we can think of something bilateral ethmoidal allergic polyposis, or we could think of something which is just normal chronic sinusitis on both sides, which is having intermittent episodes of bilateral hypertrophy of the inferior turbinates. So it could be like this. Anything which could be unilateral, it could be also that, and the other opposite side could have chronic sinusitis. So one side may have either inverted papilloma or AC polyp or chronic sinusitis. It could be any mass, which could be a vascular mass, an angiofibroma or fibroangioma. It could be anything on one side, and the opposite side, it could be because of the destruction of the nasal septum in the middle, and the transfer, or you can say the transposition, or you can say the extension of the mass from one side to another, causing it to go to the other side and causing it to have a bilateral condition. So it could be anything. So all this should be clear in your mind. So this is so far the patient's clinical profile, and the second step after taking a proper history of the patient should be the normal anterior rhinoscopy and followed by the endoscopy. So when I did the patient's endoscopy, now I did endoscopy on both sides because the complaints are on both sides. Now this is right side. Now you should know which side is which because there will be no labeling in real life. Though if you are shown a picture like this, now let me tell you, this is the patient's right side, because as you can see, this is a middle turbinate over here, and you can see this is the axilla, which is the fourth attachment of the middle turbinate to the lateral wall of the nose. This is very common. You should always, even in the surgery and endoscopy, you should look for the middle turbinate first and the axillary attachment to the lateral wall. So as you can see, this is a lateral wall over here, so obviously this becomes the midline septum. Everything, the mucosa is so congested, you can commonly see it's having a congested mucosa with a lot of reflective surface, and you can see a mass over here which looks like yellowish white glistening smooth surface mass, and most probably it could be a polyp. It has to be a polyp because it doesn't look like inverted papilloma so far, because it doesn't have a proper cobblestone appearance. So far on right side, this is the patient's polypoidal tissue seen over here, and that too, it is coming from the lateral aspect. Now this is also really important because it is shifting the middle turbinate towards the septum. Now you can clearly see this is the axilla, that's the middle turbinate, and that middle turbinate is in so much contact of the septum in the midline that is almost stuck to it, so that the middle turbinate is almost stuck to the nasal septum. Normally if you don't see this, it is not this much close to the septum because of the polypoidal mass which is coming from the area of the middle meatus. Now this becomes the area of the middle meatus. And if we go from the medial aspect between the middle turbinate and the septum, that becomes posteriorly the sphenoethmoidal recess. That is more towards the posterior aspect. But this is proper middle meatal area, and the mass is coming from the middle meatus. Probably it is coming from the maxillary sinus maybe, and hence pushing the middle turbinate more medially. So these are all the points you should be studying in your normal anterior rhinoscopy and endoscopy. So this, to get a proper diagnosis before the surgery even begins, beforehand you should be very well aware of all these simple basic points. Now if I show you, by the way, this patient was decongested because endoscopy is possible only after proper decongestion, otherwise the scope may not pass beyond the hypertrophied inferior turbinate, which you cannot appreciate very well in this image right now. So if I show you the opposite side, now this is the patient's left side, okay, and so obviously this becomes the nasal midline septum, and that becomes the lateral wall. So in this case, I am not able to appreciate the patient's middle turbinate because the entire middle turbinate area is covered by in short, the entire nasal cavity is covered by all this grape-like smooth polypoidal glistening white surface smooth polyps over here. And as you can see, this is not one single polyp, but you can see almost like multiple grape-like a group of polyps over here, which is characteristic feature for a ethmoidal polyposis which is allergic in origin. Also you can see something more. Now I hope at this point, the place where my mouse or the cursor is right now, I hope it is a blackish structure. What anyone can guess this what it is. So if the guess is right, well, let me tell you, this is a clotted blood. This is blood, and that's the clot. So this patient was having previous history of trauma, and what I could see over here is a blood clot. So I have exact no reason why this patient is having a blood clot over here, but it seems to be a blood clot, and one must be very careful. If there's a blood clot over there, he has to be having a proper clear picture in mind that this could be a vascular mass behind, which is covered anteriorly by the polypoidal changes. So you just have to keep in mind that it could be a vascular mass behind, or the patient may have had a trauma by nose picking or something like that, or maybe it got infected and may have had a episode of bleeding which had a clot over here. So always remember the consequences or the different possibilities out there. So this is a typical appearance of the ethmoidal polyposis. In some cases, inverted papilloma may look like this. It has a more cobblestone appearance, but in some cases, the inverted papilloma anteriorly is covered by a polypoidal tissue, which may mimic the ethmoidal polyposis as well. So some people take biopsies from that area, which is a strict contraindication, and the report comes as polyposis. And hence, the surgeon thinks, "Arey, this is the polyposis. Let's go with the operation directly." And then, to his or her surprise, the patient then ends up having inverted papilloma, and that can bleed like a lot. So you have to keep all these points in your mind. So after your ARS and endoscopy has been done, you almost at this stage have a clear idea that this patient could be a case of bilateral ethmoidal polyposis with secondary changes, maybe having a vascular lesion in the left nasal cavity, but I think not beyond that. The patient cannot have a JNA because, as you can see, the patient's age is so middle age. It could be angiofibroma, but more towards the fibromatous component, but typically it is unilateral and it may not look like this whatsoever. So JNA is ruled out. Any CA maxilla is ruled out because at this stage, because the patient history is not like that. But still, this history is not sufficient enough to rule out initial stages of CA maxilla so far. So major issues like the AC polyp is ruled out. Our main concern now stands for bilateral ethmoidal polyposis so far, but then we have to look for the CT scan so far. And if I show you the patient's CT scan, I have made different arrows in different colors to show you. As you can see, this patient has a coronal section over here, and this is mostly the anterior segment because you can see the maxillary sinus over here, and completely, I mean exactly completely, each and every sinus cavity is opacified. You can hardly see the bony cavities or the sinus air cells, the differentiating bony walls between them. You can hardly appreciate that because the entire structure, the entire sinus and the nasal cavity is full of opacification, full of collection. Now, this is so far on the CT scan. You cannot see any dehiscence in the lamina papyracea over here. The lamina papyracea seems to be intact. The skull base seems to be intact. The orbit seems to be normal. The maxillary walls seem to be normal. There is no destruction of whatsoever. So far, I also can show you one more photograph. So this is the other photograph. You can still see the bony anatomy is quite intact. You can see the nasolacrimal duct over here quite widened up. And you can see the opacification, hardly a space of normal aeration in the right nasal cavity, but everything else is completely opacified. But there is no bony thinning, no bony dehiscence, no destruction. This uniform density is not seen invading the orbit or the skull base or in any extra sinus or intracranial area. So far we can rule out the malignancy depending on the CT scan, and we can still go for the condition of bilateral ethmoidal polyposis with secondary blockage of all the sinuses and collection within. Also, this cannot be allergic fungal, neither it can be invasive fungal because you cannot see any allergic double density sign over here. Also, you cannot appreciate any bony dehiscence or palatal destruction or any mucormycosis changes. So this is purely a case, so far I think, a case of bilateral ethmoidal polyposis. So this is how you narrow down your differential diagnosis. The only doubt which we had in the left nasal cavity was this blood clot over here, and you can see some minor bleeding over here. So as you can see downside, we can see a suction over here. So I was trying to do a suction just to be safe because the patient had a minimal bleeding, maybe because of decongestion prior to endoscopy. So we have to consider a vascular mass behind, but on the CT scan it is very difficult to localize a vascular mass because of such intense opacification throughout. So you can see this is very much straightforward, a bilateral allergic polyposis, and only during surgery we can now know for sure whether it was having a vascular mass or not. So we did the surgery of the patient and we removed the entire sinus, we cleared the entire sinus, we cleared of the discharge, we removed all the bony dehiscence walls, not the bony dehiscence walls but the intervening bony walls between the sinuses. We flushed the entire sinus area with the skull base, so that we do not have a recurrence in future. So these, as you can see on the screen, these are the multiple small grape-like polypoidal tissues which we have removed from either side, combined, and you can see the measurements of the specimen over here. You can see how bloody red this all tissues are, and ethmoidal polyposis, if it is too allergic, tend to bleed a lot and to tend to have a lot of vascularity within. So the management part. Now, how do you manage such patients? Now, this patient, as you saw the photograph of the patient will come to your OPD with so and so complaints. You get you do all the investigations, you narrow down the investigations, differential diagnosis, you explain the patient the diagnosis, presumptive diagnosis, you give him a date for surgery, you do the anesthesia fitness. Once the patient is fit, but before that, once you try to admit the patient, you start the patient 7 days prior to the surgery on, mostly you admit the patient 3 to 5 days before, and even before admitting the patient, you start the patient on oral steroids, because the mainstay of treatment is oral steroids. Doing a surgery and relieving the load is just a part of the treatment, not the end treatment. Okay, I hope you guys understand my point. Surgery is just to decrease the allergic load in the sinus. That's not the end stage. The treatment, the main treatment, gold standard treatment, is the steroidal treatment. You start the patient on tablet deflazacort or methylprednisolone for a tapering dose, and then 7 days prior to the surgery or 5 days prior to surgery, you admit the patient, you give IV steroids, you give injection Dexa in tapering doses, 8 mg, 4 mg. Also, along with that, you give oral medications, you give antibiotics to have a safe margin for infections. And once on the day of surgery, what will this do is decrease the load for your polyps. Also, the bleeding will be very, very negligible. You will have a good field of vision. If you do not give oral medications or IV medications combined of steroids, antibiotics, this patient is not going to have a good surgery. The surgeon will be so fed up controlling the bleeding all the time, because it's going to bleed like hell if you do not give steroidal treatments. Local sprays also should be started. The most preferable local spray to be started is the case of any company which consists of fluticasone furoate and azilastine, which is a steroidal formulation. You have to get it done, and once on the day of surgery, you do the surgery properly, A to Z, remove all the infected material, clear out all the polyps, and so that the patient doesn't have a future recurrence. But during the surgery also, you have to make sure you have to keep on giving repeated steroidal washes, because this will settle down the inflammation and will decrease the load in future. So because it's a case of allergic polyposis, it tends to recur almost every time in 6 months or 1 year and so on, depending on the patient's immunology and the load of allergens in the blood system. So you have to explain the patient very well. According to the allergy, you have to get the eosinophil count done, the IgE levels done, and depending upon the levels, you have to start the treatment for the patient. So you have to also make sure that the patient does not have any samthistride, that is the aspirin sensitivity, and asthma, and the nasal polyposis. So you have to take a proper history, and after that, finally, once you have your biopsy sample ready, you go for the histopathology. Now, this is the normal histopathology which a histopathology doctor will see. Now, we are not experts in this histopath, so we don't know anything about this, but if I can give you a labeling for the same slide, it suggests that the stroma is seen with eosinophils, which will be a major factor in case of allergic polyposis, as opposed to the infective polyposis, which is AC polyp, in which eosinophils will be only a very minor factor, whereas neutrophils, plasma cells, and lymphocytes are also seen. These are all seen together in both the cases, but eosinophils plays a major role in cases of allergic polyposis. The second slide is the lining of the polyp. You can see the proper lining of the polyp over here, and if I can show you the labeling, this is a respiratory epithelium in which the stroma is edematous, and the rest is same. Eosinophils present with plasma cells, lymphocytes, and neutrophils. So once you see the patient, this is how you actually narrow down the patient's investigation, discuss the endoscopy, ARS, examine the patient, go for history, you go for the CT scan, and you go for a proper diagnosis, keep a set of differential diagnoses, and then go for the surgery accordingly. So this is how an ENT and a skull-based surgeon should approach a patient stepwise, and not confuse anywhere in between. If you have any doubts, you can go and consult your seniors. The seniors can teach you whatever you don't know at present, or even if you're in some institutes, in some colleges, seniors do not teach at all. So if the seniors are not teaching you out there, you can surely put pictures from your own OPD, and you can send the pictures to me. I can help you out. I can teach you guys out there. Maybe I can just post the video of those pictures and teach you online. So whatever doubts you have, you can let me know, and whatever steps you want to learn, just feel free to message me on my Facebook, on my Instagram, and my YouTube channel, everywhere. You can search for me. Okay, so I hope you like this video. If you have any doubts, let me know, and in the next video I'll be with you guys again with the third case, which would be a very interesting one. So till then, stay tuned, guys. Thank you so much.